stenosis and the role of stabilization and interbody spacers. Low back pain in humans is very similar to low back pain in the dogs. In humans has a huge socio-economic impact. It's staggering numbers of people that sit at home, cannot work due to low back pain. I think in dollars it's number 2 in economic losses, low back pain. So what is the story of low back pain in dogs? Well, I talked a lot about it already. If you sort of make socio-economic importance of lumbosacral disease in dogs, it is also a problem. This problem, low back pain, is common in working dogs, dogs that are trained for certain tasks, police work, for guarding, for hunting. And there was a study in Sweden on military dogs or police dogs, and 1 of 6 dogs had to retire because of low back pain. And they calculated a loss of 50,000 to 100,000 euros per dog. So it also is a problem in working dogs. And if you see what these dogs need to do with their spine, you can imagine that it puts a lot of strain on their back. There's a clear genetic influence also. We know that low back pain and degenerative lumbosacral stenosis is occurring in shepherd-like dogs, more common than in other type of dogs. But these are also usually working dogs, so that makes it a little bit difficult to deal with the genetics. However, we have, there is some literature out there that shows that shepherd dogs are predisposed for low back problems. And I've shown you the similar imaging characteristics between humans and dogs. So if we look at the signs, the clinical signs, they can be very subtle. Many of my patients with low back pain, eventually I need videos of the owner, smartphone videos, how the dog is presenting at home. So this is a smartphone video, how the dog is at home. This dog only showed some back pain when walking. This is a dog that doesn't really show any abnormalities in the gait. And as soon as I start to extend some of the hind limbs, this dog starts to yell. That is, I'm not doing a lot, but trying to extend the hind, and this dog shows a lot of pain. This dog, I showed a video again, had a history that it didn't want to jump over just small obstacles. This dog is not jumping over this obstacle, and after walking the dog, it started to, it trembled with the whole hindquarters. And in the clinic, the only thing I could find is pain on the low back in this dog. So it can be very subtle changes, and you really have to do a good history taking, and you may find difficulty in rising and sitting, jumping, climbing. Some dogs may show a clear root signature, not in the clinic, but at home on a smartphone video. And only in the later stages they may develop some weakness, some paresis, or hypertonic tail. This is a very nice example of a dog with a root signature. It's a Dalmatian dog with low back pain, with very clear lameness in one hind limb. And look at the back, how it's held in a kyphotic position, and the tail is not moving freely. And of course, this can be a dog with a hip problem. This can be a dog with a stifle problem. It can be a dog with a hock joint problem. So you have to really do a very good orthopedic examination to exclude hock, stifle, and hip, and even other causes of back pain. And this is the examination of the dog. So I do the full orthopedic examination of the limbs. I do then extension of the low back, and I do the low back pressure test that gives an indication on low back pain. If I want to extend this back of the dog, then the dog doesn't allow me to extend both hind limbs. If I do the individual extension, try to extend this limb, the dog is not working with me, it is showing pain. If I'm going to push on its lumbosacral area, the dog already knows what's coming, it doesn't, it shows pain. This is all contributing to my feeling that this dog has more low back pain than problems in its hip. Here on the other side I can fully extend the limb. No problem at all. So in this case we have lateralized low back pain. We have pain radiating to one side. If I push on the low back, you can see the other limb going up. This is what we call the root signature. So, and you need experience for this. So not if you start doing this, you will find the difference between low back pain and hip pain. It can be quite reliable in clinics to make that distinction. And again, this is dynamic in nature, so more compression on the codequina with extension than with flexion. And if we look at the disc here, I've shown you this before, we have the discogenic pain and then the protrusion, which can be in the center or can be lateralized. And all the components, the lamina and the ligament, are contributing to the stenosis. And this gives your radiating pain to the L7 and the S1 nerve root that go to the sciatic nerve. So maybe taking it back a little bit. Anatomy is also important. So at the lumbosacral area, we are here between L7 and S1. The L7 exits here, and the S1, which is this nerve, will exit one stop behind this. And the L7 and the S1, and also the L6, no, not the L6, that's already exited, so that doesn't play a role here, but the L7 and the S1 nerve roots, which are these two, they will contribute to the sciatic nerve, the big nerve to the hind limb. So anatomy is important, realizing that these two roots, the L7 nerve and the S1 that exits one stop behind this, if they are compressed at this location here, they may get impaired. So then it will reflect to the sciatic nerve. The other nerves here are the S2, the S3, and the caudal nerves. They reflect to the tail muscles and to the pelvic area, and they reflect to the bladder. So that is the reason that you may also find in these dogs hyperesthesia in the pelvic area, or a tail that is painful, or a tail that is hypertonic, or sometimes problems with urination. So if you take a radiograph, it may show you degenerative changes, like in this case spondylosis, end plate sclerosis, collapsed disc space. This is a very severe case, and you can even see the step formation. This is a normal junction, and look how nice and smooth the junction is here. In one line, L7 and S1, and in this case we have this step. If in the old days we did a contrast study, before we had CT and MRI scanners, we did contrast study with a contrast agent, and then we injected that in the epidural space. and this is called epidurography. And the only thing which we could show there is the disc protrusion by the elevation of this contrast column. Nothing more than that. So this is 20 years ago how we diagnosed degenerative lumbosacral stenosis. If you look at the spine of the human with spondylolisthesis, then you can see clear similarities between the canine with the lumbosacral instability and the human with spondylolisthesis. In the human, you will have an anterior shift of L4 from L5 or from L5 to S1, whereas in the canine, you will have a ventral shift of the cycle. So in both cases, we have instability, but in dogs, it goes to the other side, to the other direction. So we have a ventral shift of S1 in relation to L7. And that's just by anatomy and because of the difference between human biped and the dog quadruped. If we do CT scanning, we can see a lot more on the disc changes and the canal narrowing due to the disc protrusion. You can see that here. There's also little gas bubbles that you can notice in the disc. This is called the vacuum phenomenon due to big fissures in the disc that fill themselves with gas. Here you can see also the vacuum phenomenon. And here we have the disc protrusion. If we do MRI, we can see a lot more on the neural tissue. So here we have the spinal cord. It ends more or less here and then continues as the cauda equina, and it is completely compressed here by the disc protrusion. So this is the T2 weighted series, this is the T1 weighted series. On the T2 we can see the water signal of the nucleus, and in the degenerated disc we have a clear black disc with severe bulging. This is the comparison, the CT, same dog, and maybe it's not the same dog, I'm not sure, because I see here instability that I do not see in this case here. Most likely not the same dog. But we can see the protrusion, we can see the vacuum phenomenon here, the instability, but less clear we can see the neural tissue. Okay, this is the same story, and this is comparing the human MRI with the canine MRI, and we can find the similar features in our dogs with low back pain as in the humans. So, just a small talk on the conservative management of low back pain. I've talked on that in the previous talk, so remember, many episodes of sudden onset low back pain will resolve by itself. Never go in with surgery in the first event. Always treat conservatively first. But some of these cases may go from acute to chronic, and with all the degenerative changes that are similar to the degenerative joint disease that we see in joints. And we have talked about the conservative management in the previous talk. So let's now go to the surgical part. And for years and years we have done, and are still doing, the dorsal laminectomy for the dog with degenerative lumbosacral stenosis. And in the dorsal laminectomy, I tend to remove the caudal 2/3 of the lamina and the lamina of S1. So the caudal 2/3 of the lamina of L7 and the lamina of S1. I leave the facets intact, and so those are kept in place. This is the standard dorsal laminectomy for the lumbosacral area. And this is some of the operative views. Here we see the dural sac and the nerve roots. This is the S1 nerve root that traverses the disc. This is actually the disc itself, the lumbosacral disc, and it comes towards you, so it is showing protrusion. This is a type 2 disc herniation. So the disc itself is still intact, although we have also seen cases with extrusion at this level, but most of the times the disc is still closed, but it's severely bulging. So clear type 2, and here we can see the cauda equina, which is retracted, carefully retracted to one side, and this allows a discectomy. So here we go in with a surgical blade, a small beaver blade, and do a dorsal fenestration, and we do that in 2 phases, one phase on the left side and the second phase on the right side, and then when it's completed you can take out the complete dorsal annulus, which then gives you access to the nuclear cavity, and we can perform this nucleus pulpectomy. And I always do a discectomy. In all my low back cases, I do a discectomy. And again, because I think part of the pain, also in dogs with compression, comes from the disc itself, and not only from the mechanical compression. So I always do a discectomy, taking out the dorsal annulus and the nucleus pulposus. I culture in the lumbosacral area. I always culture these discs. So at this stage, I introduce a probe for a culture, for a swab, because some of these, we find in about 15%, we find a positive culture when we culture routinely in the lumbosacral disc. These dogs do not have discus spondylitis, clear, evident discus spondylitis. These are just your routine low back cases. In 15%, we culture a bacteria from that disc, meaning that they have a subclinical discus spondylitis sitting there in a degenerated disc. If we find the bacteria, then we treat with antibiotics later on for 2 to 4 weeks. Finding these bacteria is not a surprise. There is quite some literature in human low back cultures that also show that in discectomies in humans that also bacteria are found in the low back. But that's another story. Closure after dorsal laminectomy, I try to protect the cauda equina with a little piece of fat that I drape under the cauda equina and then also above the cauda equina. And why do I do this? Because I believe that this fat is a very good barrier for fibrous adhesions to the cauda equina, which may result in recurrence of low back pain. If you get fibrous attachments to the nerves, you will get recurrence of low back pain. And fat is an excellent barrier for fibrosis. It's not a belief that I have from religion, but it's a belief that I found in experimental studies where we had to do laminectomies, comparing laminectomy doing nothing, so doing in dogs. We did laminectomies in the lumbar spine, not protecting the spinal cord. Then we did laminectomy in the same dog, laminectomy with fat grafts, and then laminectomy with a artificial graft. So this was a human study that I cooperated in. And fat on histology, so these dogs then were necropsied and looked on histology. And fat has a superb barrier for fibrosis, far better than artificial sheath that you put over there, and also far better than doing nothing. If you don't do the fat and you go out, you will find a blood clot collecting here, blood will collect here, and the blood will start fibrosis. So this is the dog that I've shown you with the root signature, and this dog was videoed again a couple of days after surgery, and you can see the dramatic change in the function of the lip. And this dog only had a dorsal laminectomy, nothing more than that, and a partial discectomy. And look at the tail, how that is completely different in before and after surgery. Now the tail is held in another position, and here the dog has a lot of tail pain, a lot of pain to the low back. So quite a dramatic difference between before and after surgery. And we looked at that in more detail. We sent out questionnaires to owners, how they felt about the result of surgery. And questionnaires are subjective by the owner, but it is very apparent that owners they experience a very good result from surgery when you ask them specific questions on how these dogs function at home. So here you can see, even in the long term, this orange bar is 6 months after surgery. This is before surgery. This is scoring for low back pain. And here, so low numbers is a lot of pain, high numbers is less pain. And even in the long term, 1.5 years after surgery, they are still positive about the result of surgery. A little bit less than at 6 months. And most likely that also has to do with ongoing degeneration after surgery. We published on that in several papers, also supported that by objective measurements on the force plate. This is a study that showing force plate measurements. And what is important for you is to look at this red line. This is a control group. These are healthy dogs. If you run them over a force plate, then this is how they will propulse from their hind limbs at this level. If we look at the population of dogs with low back pain, then they are below this red line, and they never come back to the normal situation. If you ask the owners how these dogs do, they're quite positive on that. But owners are subjective, questionnaires are subjective. If we look at the force plate data, which is only a moment in time, of course, only the moment that they walk over this pressure plate, now I don't have an image of the pressure plate, and then you see that they will never, also not in the long term, this is at 6 months, this is at 1.5 years after surgery, they are still below the normal population. Owners are happy, but the locomotion is not completely normal. So this kept us also thinking whether we should do more than decompression with our surgical treatment for low back pain. And we started to look also in, because we also had cases that indeed did not better after surgery. So about 20% of our patients after low back surgery, only dorsal laminectomy, do not improve after surgery. So this was a driver for us to look into additional treatments. And we did a biomechanical study in the low back, in canine cadavers, trying to stabilize this junction. Found that that worked okay. Then we published a paper on the safe corridors for the pedicle screws, and also reported on a series of patients with severe degenerative lumbosacral stenosis that were treated with stabilization, in addition to a dorsal laminectomy. So how do pedicle screws work? This is just images from the human field, where pedicle screws are now more or less standard of care in spine surgery. So the pedicle is the connection between the lamina and the facet and the vertebral body. And this pedicle is a very good piece of bone mass to put a screw in. And the pedicle is found with this instrument, it's the pedicle finder. So the cortex is penetrated, then the pedicle finder finds the pedicle, and then the screw is inserted, a pedicle screw. This is a pedicle screw, and what is typical of this pedicle screw is that it can connect with a bar. And the connection is made with this cap and this nut. So we described the insertion points for the L7 and the S1 pedicle screws, and it's not too difficult if you are experienced in spine surgery. If you do a lot of disc herniations in this area, these landmarks are not so difficult to find. It is in the cranial facet of L7, here where the facet more or less crosses with the transverse process. That's where you should enter the pedicle for L7. And S1 is even easier. It's just caudal to the cranial facet of S1. This is where the S1 pedicle screw should enter. So this is actually the pedicle here, this piece of bone here, that connects the lamina with the vertebral body. So these screws do not enter the spinal canal. It may seem that they enter the spinal canal, but this is a lateral view. The screw is in this piece of bone here, not in the canal, of course. And this is how it looks from the top. So 2 pedicle screws in L7 and 2 in S1, and they are connected with this bar, and the bar is locked in place by this mechanism with the cap and the nut. It's a very sophisticated screw system that has been developed in the medical field for already a long term. So this is our pedicle in S1, and this is then the direction that the screw should be put in. And we also looked into that in cadaver specimens to see what is the safe corridor for our pedicle, for our pedicle screw. And again, same in the lateral view, you can see the position of the pedicle screws in relation to the sacrum, here in S1 and here in the cranial part of L7. Let's look at the case. Actually, this case was referred to us from Belgium. It was a 4-year-old Labrador, history of 2 months low back pain, was treated with epidural injections, NSAIDs, tramadol, that did not improve. Well, initially it improved, but then the back pain worsened, and it was referred to Utrecht for a second opinion. This dog had extreme low back pain, severe paresis, even had deficits, hypotonic tail. And this was the first radiograph that we received, and already here we have a suspicion of maybe more than only degenerative lumbosacral stenosis. We have an end plate that is not sharp, well defined. So this dog may also have a discus spondylitis. And this is the CT scanning, and indeed we found lucency of the end plates on L7 and S1. This is S1, this is L7, with an indication for discus spondylitis. And this is the MRI scan, a low field MRI. And And in the acute phase, we found this hyper-intense signal extending all the way to the canal, which is very indicative of discus spondylitis. This dog was treated with dorsal laminectomy, discectomy, curettage of the discus, and then stabilization with pedicle screws. Here we can see the follow-up. And then this dog was followed along the years after the surgery. This is just showing that if you do CT in the post-operative phase and you make your slice here, then you can say something about the position of the screws, which should be free from the canal. And of course, if you scan right in the middle, you only see the bars and the dorsal laminectomy here. And if you scan at the level of S1, then you can nicely see the position of the screws in the pedicle of S1. This is the dog immediately after surgery, also taking a pee, so actually functioning quite well on the first day post-operative. And this is at 2 months after surgery. And we followed this dog along until 4 years after surgery. And we see that over the years we get a complete fusion of L7 and S1 by this spondylosis bridge, not by interbody fusion. This is the dog, I think, probably at 1 year after surgery. Quite well, no deficits, happy owner, happy dog. So we were quite satisfied with that, actually with that technique. But only reserved it for the very bad cases, because the implants are expensive. So we do not routinely put implants in our low back cases. Try to stratify the dogs, and only the dogs that do not respond, that have severe degenerative joint lumbar